Let's start today second part of a lecture on local anesthesia. So we'll be talking about uses of local anesthesia, pharmacokinetics, and the systemic effects of local anesthesia, and concept of maximum safe dose, and local anesthesia systemic toxicity and its management, and others adverse effect of local anesthesia. The first, its most common use is infiltration anesthesia. Any local anesthesia can be used. And onset of action is almost immediate after intradermal or subcutaneous administration, and the duration of anesthesia varies according to the type of drug used. Bupivacaine is longer acting and lignocaine is shorter acting. And addition of epinephrine will prolong the duration of this effect, and the addition of epinephrine is most pronounced with lignocaine. And choice of a specific drug for infiltration anesthesia depend upon the desired duration of action. Those required depends upon the extent of area to be anesthetized and expected duration. When large surface areas have to be anesthetized, large volume of dilute anesthetic solutions will be used so that you do not cross the maximum safe dose, which we will be discussing later. These considerations are particularly important in infants and smaller children. And one thing to consider while giving infiltration anesthesia is patient frequently experience pain immediately after subcutaneous injection because of the acidic nature of the local anesthesia solution, and neutralization of lignocaine solution by addition of soda bicarb immediately before injection reduces the pain on skin infiltration. And another use is intravenous regional anesthesia. This anesthesia involves the intravenous administration of local anesthesia into a tourniquet occluded limb. This is also known as Beer's block. Basically, the anesthesia is given intravenously, but it does not go into the systemic circulation. That is occluded by tourniquet. Local anesthesia then diffuses from the peripheral vascular bed to non-vascular tissues such as axons and nerve endings, and then it exerts its effect. Both the safety and efficacy of this regional anesthetic procedure depend upon the interruption of blood flow. So the tourniquet should be safe. It should not give way. And gradual release of occluding tourniquet, used primarily for surgical procedure on the upper limb, and shorter surgical procedure on the foot or lower limb can also be performed. Approximately 3 mg per kg of preservative-free lignocaine, which is also known as Xylocard, without epinephrine for upper extremity purpose, and for lower extremity 50 to 100 ml of 0.25% lignocaine can be used. Cardiovascular collapse has occurred after the use of bupivacaine, so use of bupivacaine in intravenous regional anesthesia is discouraged. And the most common usage by anesthesiologists is peripheral nerve blockade. And this peripheral nerve blockade is subdivided arbitrarily into minor and major nerve blocks. Minor nerve blocks are those blocks involving a single nerve entity such as ulnar or radial nerve, and whether major nerve blocks involve the blockade of 2 or more distinct nerve or of nerve plexus. Nerve plexus means brachial plexus, lumbar plexus, or sacral plexus, where a different bunch of nerve emerge from the plexus, or blockade of very large nerve at more proximal site, that is femoral or sciatic nerve. And most local anesthetic drug can be used for minor nerve block. The onset of block is rapid with most drug, and the choice of drug is determined by required duration of anesthesia. For prolonged anesthesia, bupivacaine is used, and we already discussed about mixture of local anesthesia. The duration of both sensory and motor blockade is prolonged significantly when epinephrine is added. And brachial plexus block for upper limb surgery is the most common major peripheral nerve technique. Others are lumbar plexus, sacral plexus, and individual nerve blocks. And local anesthesia can be used as perineural and plexus infusion for continuous pain management after surgery for periods of weeks to months, and also for the treatment of chronic, malignant, and non-malignant pain. And another use is central neuralgial blockade. This is a major topic, so you'll be discussing this in separate lecture. Central neuralgial blockade includes spinal and epidural anesthesia basically. So this will be discussed in separate lecture. And topical anesthesia. And a number of local anesthesia formulations are available for topical, that is used over the skin, like Lignocaine, and Dibucaine, Tetracaine, and Benzocaine. And most commonly used is EMLA, eutectic mixture of local anesthesia. That is 2.5% Lignocaine and 2.5% Lidocaine for venipuncture or intravenous elevation and skin grafting. Most commonly used for venipuncture in pediatric population. And this must be applied under occlusive bandage for 45 to 60 minutes to obtain effective cutaneous anesthesia. And other uses, tumescent anesthesia. This is the most commonly used by plastic surgeon during liposuction. This involves the subcutaneous injection of large volumes of dilute local anesthetic solution in combination with epinephrine. And total dose of lignocaine ranging from 45 to 55 mg per kg produce safe plasma concentration, which can peak more than 8 to 12 hours of infusion. So despite this seemingly huge dosage, good outcome has been reported. And so the peak plasma concentration requires 8 to 10 hours. So the clinician should exercise great caution while administering the local anesthetic by infiltration or other route for at least 12 to 18 hours after use of this technique. And other uncommon use of local anesthesia is systemic local anesthetic for neuropathic pain. The most commonly used is lignocaine. And a broad variety of local anesthetic and among other drugs, antiarrhythmics, anticonvulsant, and other sodium channel blockers are administered intravenously, orally, and to relieve the neuropathic pain. And coming to pharmacokinetics, basically this is how the drug is being absorbed and excreted from the blood. So the concentration of local anesthetic in blood is determined by the amount of injected, the rate of absorption from the site of injection, the rate of tissue distribution, and rate of biotransmission and transformation and excretion. And other patient-related factors such as age, cardiovascular status, and hepatic function also influence the pharmacokinetics of the local anesthetic drug absorption. Though the local anesthetic drugs are given locally, but they are bound to be absorbed into the systemic circulation. They are absorbed and then metabolized. Basically, the systemic absorption of local anesthesia is determined by site of injection, and site of injection depends on blood perfusion. Also, the dose, volume, and addition of vasoconstrictor agent that most commonly used is epinephrine, and the pharmacokinetic profile of the agent itself. And comparing the blood concentration of local anesthetics, it is highest after intercostal nerve blockage. So basically, the blood perfusion of intercostal area is highest. So the blood concentration rises rapidly after subcostal nerve block, and then following decreasing order by caudal, epidural, lumbar epidural, and brachial plexus. And subcutaneous tissue is the safest, I should say. So blood concentration does not peak. The maximum blood concentration of local anesthetic drug is related to total dose. So the concept of maximum safe dose comes into play here. So if we decrease the dose, then there are lower chances of local anesthesia getting peaked in systemic circulation and lower chances of systemic toxicity of the local anesthesia. In general, more potent lipid-soluble drug, that is bupivacaine, has lower rate of absorption than less lipid-soluble drug, that is lignocaine. And after absorption, the drug is distributed. And the systemic distribution of local anesthetic can be described by two-compartment model. The rapid disappearance phase is believed to be related to uptake by rapidly equilibrating tissue, that is, tissue that have higher vascular perfusion, and most commonly these are brain and heart. The slower phase of disappearance from blood is mainly a function of particular compounds. So basically, two-compartment model. Local anesthetic drugs are distributed throughout all body tissue, but more highly perfused organs show higher concentration of local anesthesia, that is heart and the brain. Because local anesthesia are rapidly excreted by a long tissue, the whole blood concentration of local anesthesia decreases markedly as they pass through the pulmonary vasculature. So you just remember that the higher concentration of local anesthesia is seen in heart and brain. And biotransformation, the pattern of metabolism of local anesthetic agent depends on their chemical classification. They are chemically classified as esters and aminoamides. The esters drug undergo hydrolysis in plasma by pseudocholinesterase enzymes, and aminoamide drug undergo enzymatic degradation primarily in the liver carboxylesterase and cytochrome P450 enzyme system. Excretion of metabolite of amide type local anesthesia occurs by kidney, and less than 5% of unchanged drug is excreted unchanged into the urine. And patient status also affect the pharmacokinetics. And in a study, it is shown that half-life of lidocaine after intravenous administration average 80 minutes in young volunteers, and the half-life was prolonged to 138 minutes to 60 to 70 years older population. So rate of excretion is slower in older population, and newer infant have immature hepatic enzyme system, hence prolonged elimination, because aminoamide drugs are metabolized in liver. Decreased hepatic blood flow or impaired hepatic enzyme function can produce systemic substantial elevation of blood level of aminoamides. And aminoamides local anesthetic are most commonly used. Most commonly used are bupivacaine and lignocaine. Both are aminoamides. And basically, the most commonly used drugs are bupivacaine, lignocaine, and ropivacaine. So these drugs will show systemic toxicity if used in higher dose. So there is a concept of maximum safe dose. You need to memorize that. So the maximum safe dose of lignocaine without adrenaline is 4 to 5 mg per kg, and that of with adrenaline is up to 7 mg per kg. Bupivacaine and ropivacaine both 2 mg per kg. So while giving local anesthesia, you need to keep in mind you should be giving lower than maximum safe dose. Local anesthetic drugs are usually considered safe if administered in appropriate dose and in the correct anatomical location. So anatomical location means while you are giving intercostal nerve block, there are high chances of systemic toxicity. So you should be more careful. How systemic and local toxic reaction can occur because of accidental intravascular intrathecal injection or administration of unwanted excessive dose. In addition to specific adverse effect associated with certain drugs. Okay? Allergic reactions are more common in amino ester drugs, and methemoglobinemia is particularly peculiar to use of lidocaine. Systemic toxicity. Systemic toxicity reaction of local anesthesia primarily involve the CNS and cardiovascular system, because these are both the CNS and cardiovascular system are dependent upon the action potential and then electrical. In general, the CNS is more susceptible to actions of systemic local anesthetic than the cardiovascular system. Basically, under lower plasma concentration, CNS effects are seen, and if the plasma concentration is higher, then cardiovascular toxicity is seen. And thus, the dose for blood level required for local anesthesia produce CNS toxicity is usually lower than that requiring circulatory collapse. So this table shows the plasma concentration and corresponding effect. Usually 1 to 5 mcg per ml will show analgesia, and as you go on, as the plasma concentration goes on increasing, first CNS symptoms are seen, that like redness, tinnitus, numbness of tongue, then it progresses to seizures, unconsciousness, and coma, respiratory arrest, and finally cardiovascular collapse, cardiovascular depression, collapse, and fatal arrhythmias. Basically, CNS toxicity. CNS toxicity is because of CNS excitation, which may be the result of initial blockade of inhibitory pathway in cerebral cortex by local anesthetic drug. Local anesthetic drug are sodium channel blockers, right? But they are postulated that it can also be result from stimulation of the release of glutamate. Glutamate is excitatory amino acid, right? And blockade of inhibitory pathway allows facilitated neurons to function in unopposed fashion that results in convulsions. And further increase in the dose leads to inhibition of both inhibitory and facilitated circuit, which results in generalized state of CNS depression and coma. In general, the potency of local anesthetic is correlated with CNS. So, bupivacaine is more toxic. And one thing to remember is respiratory or metabolic alkalosis, acidosis increases the risk of CNS toxicity from local anesthesia. If you remember this, it is important while management of the local anesthesia systemic toxicity. And increase in PSO also enhances the cerebral blood flow. And thus, anesthetic is delivered more rapidly to the brain. These 2 points are important while management of the local anesthesia systemic toxicity, respiratory and metabolic acidosis, and increase PaCO2. The clinical implication of this effect of hypercapnia and acidosis on toxicity deserves emphasis. Seizures produce seizure because of CNS toxicity produce hypoventilation and combined respiratory and metabolic acidosis, which further exacerbate the CNS toxicity. In the setting of local anesthesia toxic reaction, it is essential to provide prompt assisted ventilation so as to decrease the respiratory and metabolic acidosis and decrease the PaCO2. And circulatory also support to prevent and correct hypercapnia and acidosis, and also prevent or correct hypoxemia. And in higher doses, cardiovascular systemic toxicity occurs. Local anesthesia causes cardiovascular toxicity in 2 ways. Either they exert direct action on both heart and peripheral blood vessels, as well as indirect action on the circulation by sympathetic blockade or parasympathetic activity. Direct cardiac effect, because cardiac tissues are also excitable tissues. So it is understood that the sodium channel blockers are going to affect the cardiac tissue. So basically, the local anesthesia decreasing the rate of depolarization in fast conducting tissues of Purkinje fibers and ventricular muscle. And this reduction in rate is believed to be due to decrease in the availability of fast sodium channels in the cardiac membrane. So the sodium channel blocker effect is seen, and it will decrease in rate of depolarization. And also action potential duration and effective refractive period are also decreased. And one thing to remember is bupivacaine. It is more cardiotoxic. Bupivacaine depresses the rapid depolarization phase to a greater extent than lidocaine. All local anesthesia also produce dose-dependent negative inotropic effect. Negative inotropic effect means that is force of contraction. So all local anesthesia exert would decrease the force of cardiac contraction. And another hypothesis is local anesthesia may depress myocardial contractility by affecting calcium influx and trigger release from sacroplasmic reticulum, and as well as by inhibiting the cardiac sacroiliac calcium currents and sodium current. Basically, they also are believed to be blocking the calcium currents apart from sodium channels. And direct peripheral vascular effects are basically, apart from cocaine, all other local anesthesia exert biphasic effects on peripheral vascular muscle. At lower concentration, vasoconstriction, and at higher concentration, vasodilatation. And but cocaine is the only local anesthetic that is, but this is not usually used, but that is consistently causes vasoconstriction at all concentration. And comparative cardiovascular toxicity, especially bupivacaine. Bupivacaine can cause rapid and profound cardiovascular depression. Ventricular arrhythmias and fatal ventricular fibrillation can occur more often after rapid intravenous administration of large bolus dose of bupivacaine, but less frequently with lignocaine. And the CNS effect of local anesthetic may contribute to the generation of arrhythmias also. And pregnant patients are more susceptible to cardiovascular toxicity of bupivacaine. And another thing is cardiac resuscitation is more difficult and unfruitful after bupivacaine induced cardiovascular collapse. And if at all local anesthesia systemic toxicity occurs, then you need to manage it. You need to know how the principles of management. Basically, ventilate with 100% oxygen to decrease the respiratory acidosis and increase the PaCO2. And if at all seizures occur, benzodiazepines are preferred. Benzodiazepines means midazolam or diazepam, whatever is available. But avoid propofol. And alert the nearest facility with cardiopulmonary bypass. And management of if there is cardiovascular collapse also occur, then basic and advanced cardiac life support will be required. And avoid vasopressin, you will not know that, but ACLS and BLS system are activated, and if available, 20% lipid emulsion therapy. That should be given in bolus and with continuous infusion. This is the like an antidote for local anesthesia systemic toxicity. But as mentioned that bupivacaine induced local anesthesia toxicity is difficult for resuscitation, and often the resuscitation is unfruitful. So the patient may require cardiopulmonary bypass also. And this is the graphic representation for local anesthesia. Call for help, support ventilation, stop seizures with midazolam, and initiate ACLS and alert nearest cardiopulmonary bypass facility, and then lipid emulsion therapy. Bolus with 1.5 ml 4 kg and infusion, and then again assess. The bolus can be repeated or can be doubled. Then the patient should be monitored for 12 more hours. If unfruitful, then the patient should be started on cardiopulmonary bypass, which is not usually available. Thank you.